When you or, someone you love gets a serious diagnosis like breast cancer, everything just stops.
The world pauses.
Yeah. And in that moment, what you desperately need is certainty, an accurate forecast.
You're relying on these modern diagnostic tools to tell you exactly how aggressive this disease is and, well, what fight lies ahead.
But what if those standard tools, those tiny molecular snapshots we rely on, what if they consistently give a misleadingly optimistic prediction?
It's not just a hypothetical problem. I mean, it's a critical challenge we see in the medical literature,
Right.
particularly when you're dealing with the most fatal cancer subtypes.
Right.
For years, we've relied on what we call molecular biomarkers.
Okay, so let's define that for everyone.
These are the chemical flags we look for in a biopsy. So things like the estrogen receptor or ER, progesterone receptor, PR.
HER2 expression, Ki-67.
Exactly. They tell us about the cell's internal chemistry, and that guides hormonal or targeted therapy.
And that system has become the gold standard. It's the traditional method for prognosis. But our deep dive today focuses on this really stunning 2023 study in the European Journal of Radiology.
From Tabar and his colleagues.
Yes, and they argue that we need to pivot. They suggest we have to start prioritizing something entirely different, imaging biomarkers.
And for very good reason.
Yeah.
Imaging biomarkers are essentially the visual anatomical information.
What the radiologist actually sees on the mammogram.
Before surgery, yes.
Yeah.
It's the shape of the disease, its precise extent, the patterns of calcifications. Unlike the molecular test, which is a chemical readout, the imaging biomarker is. It's a physical map.
A map. I like that.
It reflects the overall tissue structure and the cancer's anatomical site of origin.
Okay, so let's unpack this because the stakes are incredibly high. The research team analyzed data from over
2,236 breast cancer cases.
diagnosed over a decade, from 2008 to 2019. Their mission was pretty straightforward. Figure out which set of markers, molecular, imaging, or a combination, was the most reliable predictor of long-term survival.
And the data, well, it revealed a profound disconnect between the chemistry and the anatomy. It forces a necessary and a really difficult reevaluation of how we assess risk.
The core issue, then, is something you call heterogeneity.
Right. The foundational issue the study spotlights is tumor heterogeneity. Molecular biomarkers are fantastic for predicting the outcome in cancers that are unifocal, so one uniform, predictable tumor.
But that reliability just crumbles the moment the disease gets complex.
Varied, or as we say, heterogeneous.
When you say heterogeneous, you're saying the cancer isn't just one type of cell, it's a mixed bag of threats.
Exactly. Think of it like a battlefield with multiple enemy factions, and each one needs a different strategy. If you only interrogate one faction, you miss the larger threat.
And the study gives some really clear examples of this. Let's start with the first one, intertumoral heterogeneity.
This is when you have multiple distinct tumor foci existing side by side. For instance, in multifocal acinar adenocarcinoma of the breast, or AAB, they documented a case of a 78-year-old woman with multiple cancer nodules. One was a slow-growing mucinous carcinoma, and right next to it was a highly aggressive, diffusely infiltrating carcinoma.
So if a surgeon goes in and takes a biopsy, just a small sample, they risk only hitting one of those targets. What happens when they test those different areas?
The markers are completely contradictory. The mucinous focus was positive for PR, had a high Ki-67 index, which indicates a fast proliferating but maybe hormone-responsive tumor.
Okay.
But the adjacent, much more dangerous diffuse focus was negative for PR and had a low Ki-67.
Wait, low Ki-67? That usually suggests a slow-growing, lower-risk cancer, the kind that might not need aggressive chemo?
Precisely. If the pathologist mistakenly chose that diffuse focus for analysis, the patient would be categorized as low risk,
leading to undertreatment.
For the aggressive disease component that was actually present, the prognosis, and therefore the treatment, is entirely dependent on what part of the tumor mass was chosen for the biopsy. It's a diagnostic roll of the dice.
And the patient's life is the stake. That's unsettling, but that's just different areas. What about complexity within a single tumor? That brings us to intertumoral heterogeneity.
Right. This is where two entirely different tumor types are coexisting within the same physical lump. They described a mass where the core was this solid, highly disorganized component.
Okay.
And it carried unfavorable markers: estrogen receptor negative, HER2 positive. But this aggressive core was surrounded by a shell of cells with favorable markers, ER positive, HER2 negative.
So you have a hard shell of good news cancer wrapped around a core of bad news cancer. Which one dictates the outcome?
The aggressive, unfavorable central component, the one with the highly disorganized cells. The researchers called it pleomorphic. That was the component that had already invaded the lymph node and was driving the metastatic potential.
And a standard biopsy might just skim the surface.
And give the patient the false comfort of the favorable outer shell. This problem of heterogeneity, of misdiagnoses, it leads us directly to the most fatal, diffuse cancer types, where that molecular snapshot consistently fails.
This is the core point we wanted to zero in on. If molecular tests can be tricked by this complexity, how does the anatomical picture, the imaging biomarker, provide a more reliable compass?
Because imaging classifies cancers based on their anatomic site of origin. And the study strongly confirms that this is a profoundly better predictor of long-term outcome than our current standard molecular classification.
So let's start with the baseline, the majority of cases where molecular markers do work well.
That would be the axon or adenocarcinoma of the breast, or AAB. This type accounts for, roughly 75% of all breast cancers.
And it looks a certain way on the mammogram.
Very distinct, recognizable imaging features. Things like powdery calcifications in grade 1 in situ disease, or a spiculated star-like mass when it becomes invasive.
And for those, the molecular test works.
For AAB, yes. The molecular classification, often falling into the luminal A subtype, it reliably predicts a good long-term outcome, especially when the tumors are small, less than 15 millimeters.
So the tests are in agreement there.
The molecular test and the imaging test are in agreement.
Okay, that's good news for the majority. But where does the system break down? And I mean, how high is the cost of that breakdown?
The breakdown happens dramatically in the two high-risk diffuse subtypes. Listen to the statistic.
Okay.
These two types comprised only 21% of the cases in the study.
Just over a fifth.
But they accounted for a staggering 45% of all breast cancer deaths.
Wow. Half the deaths from a fifth of the cases.
We are talking about the cancers that kill. And that's where molecular testing falls apart.
We absolutely need to focus on those 21%. What are those two fatal subtypes?
Type 1 is BCMO, or breast cancer of mesenchymal origin. This is a conventional and a classic invasive lobular carcinoma. It accounts for about 5% of all cases.
And what does the imaging biomarker tell us about BCMO? What's the visual signal?
The signal is extensive architectural distortion without calcifications. The mammogram shows the tissue structure being pulled and disrupted across a wide area.
So it looks chaotic.
It does. And this visual distortion is the imaging biomarker, and it accurately predicts a very poor outcome for the patient. But here's the critical failure of the molecular test.
Okay.
BCM tumors are usually ERPR positive, HRR2 negative, and have low Ki-67.
That, by definition, is luminal A, the favorable prognosis classification.
Exactly. You have the imaging maps screaming high risk, poor prognosis, while the molecular chemistry is whispering low risk, luminal A, go easy on the treatment.
That sounds like a devastating systemic failure. It leads directly to undertreatment. How often did this misclassification happen?
The study quantified it. 81% of BCMO cases were classified as luminal A.
81%. 4 out of 5 of these highly lethal cancers are getting mislabeled as favorable.
And the predictive accuracy of the molecular biomarkers for BCMO, it literally falls apart over time. The area under the curve, or AUC, which measures a test reliability, it dropped from 68% at 5 years down to only 59% at 10 years. The certainty of the molecular result just collapses.
So the system is fundamentally telling doctors to be less aggressive with the cancers most likely to kill the patient. That's a huge misleading prognosis built into the current standard of care.
It is.
So what about the second high-risk type?
That is DAB, or ductal adenocarcinoma of the breast. This subtype originates from the major lactiferous ducts. It makes up about 20% of cases.
What visual clues does DAB give the radiologist? What are they seeing?
DAB has 6 specific high-risk calcification patterns. Patterns they describe as like fragmented casting or skipping stone-like calcifications.
Okay.
It can also appear as non-calcified architectural distortion caused by something called neoductgenesis, the formation of new chaotic ducts.
And those visual cues, the imaging biomarkers?
They reliably indicate a high risk of death, yet just like BCMO, molecular tests frequently suggest a good prognosis.
Why does the molecular test miss the mark here? Is it another heterogeneity problem?
Absolutely. DAB cases often showed a luminal A classification in 53% of cases.
Over half.
Right. And this happens because the molecular markers are frequently taken only from an associated AAB component that happens to be next to the ductal disease.
So they're sampling the wrong neighborhood.
The molecular analysis is ignoring the more aggressive, fatal DAB component that is driving the patient's actual risk profile. The sampling is geographically flawed.
This makes the need for the physical map, the imaging, undeniable. What do the survival curves in the study look like when you compare these predictions?
Well, the survival curves, which are essentially the graphic representation of patient outcomes over time, they demonstrate the whole thesis.
They tell the story.
They do. For the predictable, common AAD cases, the line showing survival predicted by molecular markers almost perfectly tracks the observed patient outcomes. The prediction matches reality.
But for DAB and BCMO?
The curves diverge wildly. The dotted line representing molecular prediction significantly overestimates survival, sometimes dramatically, compared to the solid line of observed, much poorer survival.
The molecular markers are telling doctors the patient will live longer than they actually do.
That's the bottom line.
So the single biggest takeaway for you, the listener, is that for these complicated, diffuse, and multifocal cancers, the ones most likely to be fatal, we cannot trust the isolated molecular test results as the sole prognostic factor.
The map must supersede the chemistry.
Right.
Precisely. The study's conclusion is bold. In multifocal AAB, DAB, and especially BCMO cases, imaging biomarkers must be prioritized over molecular biomarkers when planning treatment.
Because the chemical snapshot is just failing.
It's failing to predict disease severity and long-term risk in the patients who need the most aggressive intervention.
And realizing the true extent of these diffuse cancers requires a major shift in how we analyze the tissue itself, right? Because if the disease is spread out, a tiny biopsy sample isn't enough.
It demands a return to comprehensive anatomical pathology. To truly leverage the data from the mammogram, the study insists on using large-format thin-section histopathology. We're talking about slides that are 10 by 8 centimeters.
Wow. To put that into perspective, what size is a standard tissue sample? Are we talking about going from like a postage stamp to a postcard?
Roughly, yes.
Yeah.
And the current reliance on small-section histopathology risks either over or under treatment because you simply cannot accurately map the full extent of a diffuse disease on a small slice of tissue.
It's a keyhole view.
It is. If the cancer is spread out across 4 centimeters and your slide is only 1 centimeter, you have no way of knowing how much disease you left behind.
That speaks volumes about the limitations of current practice. And the study, it specifically critiques the terminology, right? It suggests that the way we classify DIB is often as non-invasive, like DCIS, or just micro-invasive.
Which is how you end up with dangerous undertreatment. If the full extent of that aggressive ductal component isn't captured and recognized in the pathology report, the surgeon and oncologist are working with flawed data.
Leading them to less radical but potentially insufficient therapies.
Yeah.
So what does this all mean for the future of diagnosis? It seems like the anatomical picture from imaging. It provides this critical long-term prognostic factor, especially for the cancer subtypes that are most likely to be fatal.
It provides the crucial context that a single molecular snapshot often misses because of those diffuse growth patterns and that tumor heterogeneity.
We need the map as much as we need the chemistry.
If not more, for the high-risk cases. And if we connect this to the bigger picture, the study posits a really compelling biological explanation for why the molecular markers fail so spectacularly for BCMO.
Okay, why?
These tests, like for ER, PR, and HER2, they were designed primarily to analyze tumors of epithelial origin.
Which is where most of these AAB tumors come from.
Correct. The correct tools for the correct job.
Right.
But BCMO tumors, breast cancer of mesenchymal origin, they are fundamentally believed to be derived from mesenchymal hybrid cells, a structurally different starting point.
So we're trying to read a mesenchymal tumor using tools optimized for an epithelial tumor.
A completely different underlying biology being analyzed by the wrong set of standard operating procedures.
And that raises an incredibly important and I think provocative question for the research community, doesn't it?
It does. If the anatomical site of origin determines the true prognostic severity, if the picture is more important than the single chemical reading, how should the medical community reevaluate and redesign molecular testing?
To specifically target the unique biology of these high-fatality, anatomically distinct subtypes like DAB and BCMO.
The goal isn't to ditch molecular testing entirely, but to ensure that the test you use actually matches the threat you're facing.